The knowledge base of what we do in medicine needs to have advanced to the point where you understand what a cell secretes, how cells communicate, and what growth factors are, and what an exosome is, and the different types of things. The medical industry as a whole, and in particular, I think Big Pharma, realized very early on that cell therapy was the way the human body works, and they had to get ahead of the narrative before the science of using your cells to help you heal got kind of out of control.
Welcome to the Zero Downside podcast. I'm Michael Mitchell, one of the co-hosts for the show, and with me is Dr. Wade McKenna, fellowship-trained orthopedic trauma surgeon, and we're here today to kind of change up the format and just the discussion. So with that, I'll kick it off to Dr. McKenna.
Thanks. You know, going through format on this is kind of interesting sometimes because all I really want to do is provide educational content and kind of rage against the machine a little bit as far as the narratives that are out there, because I think that for the most part, a lot of the doctor-patient communication is so muted that the narrative gets presented wrong. And it happens to us too. I mean, you can talk to a patient a lot of times and what did he say? Oh, he said, I need surgery. That was it? Like you had a 20-minute, 30-minute office visit with me and all you got was surgery. Or he said, I didn't need surgery. Like people are so keyed in to one thing because of the nerves associated with the visit. And I think that's, first of all, just a little piece of advice. That's a really good reason if you go to the doctor to take someone with you. Because sometimes the person that's not sitting there worried the whole time about what that MRI report's going to say or what the doctor moving your arm that your arm doesn't move and the pain you're going to have because you know the guy's going to move something and the whole reason you're there is because it hurts. So there's a little bit of anxiety. And there's a white coat syndrome is real too. There's a lot of great studies to show that's why I don't ever wear a white coat. Well, that's not why, but we're going to pretend that's why. But white coat syndrome, meaning that people get anxious, heart rates go up, and you can't really be a great active listener when you have a little bit of anxiety. I think that our goal in the podcast format is, from a patient education standpoint, to be able to have a conversation where you're sitting in the living room with a family member listening to something that you're probably going to have, you or someone you know is going to be able to identify with. That's always our goal. And this podcast, I think because of the week we've had, going back to two patients in particular that have already seen several physicians before us and come into the clinic with what I felt was a pretty dramatic either misinterpretation, which I'm going to give.
That's being polite.
I'm going to give those people the benefit of the doubt, not the patient benefit of the doubt. The patients are right. That is probably what they heard. For sure it's what they heard because that's what they say they heard. So even if it's not what was told them, it certainly what they left the office with that impression. And we know for sure because both of them were set up for fairly significant interventions that when they saw me, I'm pretty convinced there are other options. And they were both been told either hurt until you can't move anymore or just go ahead and do the replacement now. And I don't think that for sure that's neither of these patients' only option. And because neither one of them had anything else done other than a steroid shot, that, by the way, hopefully if you've watched any episodes of the podcast before, you know how I feel about steroid shots near a partial thickness tendon tear or a full thickness tear. They're never going to help it heal. Steroids are catabolic. They only destroy tissue. It can give you short-term relief of synovitis. If you have inflammatory pain, it's going to come right back. There's no great evidence to show that steroids next to a partial thin tear are any more effective at 6 weeks than just a shot of local would have been at that time. So if it's not going to make a big long-term difference, why hurt the quality of your tissue? Now, that being said, let's go back to our episode. We're going to focus on body part. Like, this is going to be about the shoulder and the proximal shoulder girdle, what we would consider range of motion. I think a lot of people with shoulder pain, it's their neck, but it becomes their shoulder. I think a lot of people with cubital tunnel, it becomes their shoulder. So we're going to focus on the shoulder today because, and we're also going to start that there's always going to be, hopefully, maybe not always, but there's usually going to be papers in front of us because I want to give people some of my interpretation of what's in the literature, because I think it's really difficult if you're a patient that doesn't have, 15 years of 9 years of postgraduate education in anatomy, physiology, the surgical healing, to understand some of this. Like, I can't read a professional engineering article on building a house or anything because I don't understand it. But from a medical perspective, hopefully, I could interpret it and put it into layman's term for you. So we're going to try to do some of that in every episode. So I want to be able to go over because I want people to have, because I know that when you go see the doctor and you talk to him about stem cells or peptides or wellness at all, there's no evidence, it's not written, it's not published. It is. Know this. There's nothing we just make up as we've gone, right? Everything we have done has great physiologic background for how it would work, or we wouldn't do it. And if everything that Western medicine did already worked, I would have never got to this point. This was how the patients have driven care, not me. I didn't just decide to not do surgery on stuff. I'm a surgeon. I know that there are some people that didn't need as big a surgery as I thought they did because they didn't want it and they wanted to pursue a more conservative option. So my job was perusing through scientific literature, what other options could we come up with? And I've been in some very unique positions in my past for the use of bone marrow in trauma patients for fracture healing, before it was even really called a mesenchymal stem cell, because this is the same year that paper was published, calling it a mesenchymal stem cell, was when we really started using a lot of bone marrow, and it was published for non-union and complex fracture patterns. There, that being said, so the conservative options for a lot of patients have been, you're told by your physician that there's not any literature on it. I'm going to show you the literature on it, hopefully, and at least give you some sense of that this is well published, especially with bone marrow aspirate concentrate. If you just look up stem cells, that's going to be difficult. Now, if you go to Google Scholar, or you go DuckDuckGo or Brave, maybe not as much DuckDuckGo lately. Some of them bought them, I don't know. But if you do a search and you put the word stem cell in, sometimes you may have to put bone marrow aspirate concentrate. Sometimes you may have to put BMNCS, like there's a bunch of different initials, but basically it's autologous cell therapy or autologous biologics, meaning something from you. And still, if you search stem cell, there's still going to be PRP articles come up, which aren't stem cells, but it is growth factors isolated from you, so it is autologous from your blood. But if you look up PRP and stem cell, maybe is the way to do it for some people. But there's just with the machine we use, just with the Magellan, just with our kit, there's 6,500 papers published over the last 20 years on the significant contribution of autologous cell therapy. And then from a surgical perspective, we're going to cover, again, our first foray with bone marrow was in surgery patients because it made such a big difference in infection and recovery. It turned very quickly into, can you use it without surgery? But there are some patients, and that's what we're going to talk about today, that may need a significant surgery. The rotator cuff deficient patient is a big deal, and it's a lot of people. And early on, 12 years ago, I knew it was going to, the rotator cuff deficient patient was a problem because I became a rotator cuff deficient patient. And when you start going through the literature on what your options are, you find out there's not great options. And so I needed to come up with a way more minimally invasive approach, hone that down, get a bunch of experience with it before I was going to make a decision on my shoulder that could have kept me from being able to do the job I love, right? And that's back to Mike, how we kind of met, right?
That's kind of our origin story.
Yeah. So Mike was the rep for the prosthesis that turned into the paper on rotator cuff deficient shoulders. And I'm performing that surgery, and with that implant that I had repurposed and developed into a procedure for rotator cuff deficient shoulder that I was calling humeral acromial arthropathy, because the humerus rides against the acromion. There's no cup between it. Mike comes into the OR to introduce himself, and because he didn't know I had developed this technique and he had just been to training, was going to show me and explain to me how to do it.
I have to defend myself for one moment. So
Yeah.
I was in my 20s, naive enough to think I knew enough, but reality says that didn't happen.
No, I think it's valid though, because most guys have never done this procedure.
Yeah, I was a researcher, and I got told about you ahead of time, and they said, "Hey, there's this guy. You know, he's 60 minutes outside of Dallas. He's legit. You know, he's good. He's a researcher. He really dials in on surgery. But you better have your act together." And so I requested from the company, give me everything I need to be successful when I walk in and meet him for the first time, right? And help me prepare to meet him. And so they flew me to another part of the country, and I met with a physician.
Miami.
Yes.
Way better than where I was at the time.
It's a different venue.
A little different venue than Wise County.
So I meet with the only other guy that I found that had attempted this type of surgery. And he trained me, showed me how to do it. And so I came into the room thinking I had enough, right? I had enough knowledge to help enhance what you were already doing, right? With my knowledge and the company backing and all this stuff. So again,
And
in
to be
my
fair,
20s,
you hadn't been told that I had done
they missed
this for the last 2 years.
Yeah, that might have been omitted, and I probably should have looked at that.
Literally was the first one to ever do it this way.
Yes. Yeah, that was omitted by the company, so it wasn't quite explained to me. So I come into the OR and I'm ready. I mean, I have researched for hours, and I'm here to help. Right? I wanted to kind of flex my knowledge.
You knew all the steps.
Oh, I'd memorized
and had
everything.
all the hardware set out in order, because the kit to do this partial joint replacement had a lot of steps.
Yeah.
But I only designed those steps to try to make the procedure kind of idiot-proof, and not idiot-proof, but when you design a surgical procedure, or when you develop a prosthesis, and when you develop a technique, the goal is to not make it so technically complicated that you can't reproduce the results. But you have to include enough technology where people are going to have a little guidance in how to perform the procedure.
Right.
And so I had a lot of steps in that procedure, and a lot of guides, and a lot of measurements that people needed to take that I didn't need to do, because I had done so many of them, and because I had a really good understanding from spending a lot of time with proximal humeral models on exactly where I wanted to put this little prosthesis to get patient the maximum benefit, and because I changed where I put that prosthesis based on that individual patient's biggest problem. And because I looked at the rotator cuff footprint, and because I'd been through the MRI with the patient, and because I'd done motion studies a lot of times, even with a little lidocaine in the shoulder, where I would do a block at the AC joint and then move them around. So I had pretty much knew exactly kind of what I was going to do before we get to the OR. And it may not have been the way we had designed the procedure, because I designed the procedure to try to turn it into a 6-inch putt. The example I always use on PGA, 95% of 6-inch putts are made. less than 50% of putts over 8 feet are made. You don't want a surgery procedure to be an 8-foot putt because you don't want 50% of people to not be able to reproduce the result. So you try to design a procedure to where it becomes a 6-inch putt. Mike shows up in the OR. He has the tech and everything's laid out in order
Perfectly.
And I just grab a bunch of different pieces and I put them on the back table away from me because
you set them down on a stool.
Well, they're in my
you got
way.
them out of the sterile field.
Yeah, they were in my way.
Yeah. I'm mortified at this point, by the way.
Mike is wondering, how am I going to do this?
Yeah.
Well,
do you remember what you said to me? You said there's about 24 steps in this technique, and it's designed for a Hill-Sachs lesion. I'm doing something different with it. And you said, I've designed a technique, and I'm like, wait, what? And then you said, there's about 24 steps in this. I think you need about 12. And you proceed to take my sterile instruments and set them off the field.
So meticulously
and then
set
you
up.
Said,
I was so proud of you.
And you said, I'm going to go finish prepping the patient. I need you to figure out your 12 steps. And in my head, I'm just like, well, this is my last day here, so why not?
This is a long time ago, by the way.
Yeah.
So 12 years ago, I was in a really unique position where I was by myself, and it's really hard to keep a really high bar all the time. And you have to be your own worst critic and your own peer review. And so I tried to maintain a pretty reproducible atmosphere in the room where there wasn't a lot of distraction.
Yeah. No, listen, you enjoyed it.
The patient was obviously the most important person in that room.
100%.
And I made sure that it stayed that way.
The narrative is you knew what steps I was going to have to take. You were going to let me make a mistake. I think you just wanted to see how I would respond to see if it was a good fit.
Well, I mean, honestly, it was fun for me.
It was. I'm well aware you enjoyed it the whole time. Because he comes into the room and he proceeds to, in our experience, we found that. And I let him talk. And I didn't say anything really, I think, to about the first half of the case, because my approach is not the approach that Mike had ever seen. Even my incision was in a totally different location than what Mike had seen on every other shoulder he had ever seen. And so I'm trying to explain to him the approach a little, but pretty much I don't talk. And I get down to where it was, and Mike's the whole time like, his eyes are big, and he's trying to like tell the tech what's going to come next, and that was never what was going to come next. And about the time I get the implant in place, and it took about 15 minutes. Yeah.
And Mike was prepared for like a hour and a half long surgery. And about 15 minutes, I'm moving the arm around the implants, and I'm saying, what do you think? And he's just like, well, when we have done it, I said, okay, so I have a question, like, who's we, right? Because what Mike's like, well, there's a paper. I go, have you seen whose name's on the top of that paper?
I brought the wrong paper. I brought the paper that had been published the year before.
Yeah. So that paper is this paper, and it is the outpatient treatment of rotator cuff arthropathy for full thickness retracted defects, written by me. So the operative techniques in shoulder surgery from 2015 is where a 35-page paper is published on how to do this procedure and who to do it on. And the only reason it was even worth reading probably was because I had a big flow chart in there, because I think we've established, I think, of things in flow chart format. And it was kind of life-changing for a lot of people because there was nothing else out at the time that really addressed the real pathology of the problem, right? So anyway, so that's our meeting, right? That turned into, there was a point where once we start having these type of results, and you're going to see a video, hopefully, near the end from a bunch of patients between about 2010, 2012, that of all ages, a lot of them elderly, that were told they had no real option with the shoulder. They just needed a complete replacement. And a replacement without a cuff has a significant morbidity and limitations of function. You can't really lift, push, or pull more than 25 pounds for like the rest of your life. And you can get motion back. It can be for pain control, but failure of that prosthesis is really high at 5 years. And the redo rate, oh, and by the way, you burned all the other bridges. Yeah. If you cut the whole humeral head out,
there's no coming back.
No, and my aunt, like, first of all, the humeral head wasn't even the pathology. The pathology is the rotator cuff, right? For most people with shoulder pain, the problem is the rotator cuff. Mostly. Because the rotator cuff can lead to a big inflammatory load that becomes adhesive capsulitis, that becomes restriction of motion, that you have to examine a patient to be able to know what their diagnosis is.
Well, if you don't mind, cover your humeral head depressor, because when you taught me what happens in a rotator cuff deficient patient with the humeral head riding up and creating a pseudo joint, right? Can you cover that?
Yeah, so that's just it, right? So when you talk about a joint replacement, you're replacing the glenoid, which is the cup part of the shoulder, and the humeral head, which is the round ball. In a rotator cuff deficient shoulder, that's not what hurts. It's the fact that the rotator cuff sits on top of the humeral head underneath the acromion, the bone that you feel on top. So the rotator cuff acts as kind of a spacer that prevents the humeral head from riding out of the joint. It keeps the joint depressed. It's a humeral head depressor that helps you get leverage, because if the humeral head slides up every time you use your deltoid, you can lose a lot of strength and power and forward motion. So to keep the humeral head positioned, because it's a pretty unstable joint if the tissue around the shoulder isn't there. So in the hip, it's not a very unstable joint. You can remove a lot of tissue around the hip. Most total hip patients, especially back in the day, especially if you do a posterior approach, you destroy the posterior capsule. A lot of total hip, they do a total capsulectomy. They take all the capsule off a joint, and they remove a lot of the small external rotators behind
there's no soft tissue left.
No soft tissue. And the joint, a hip, because it's kind of a socket joint, is very stable. The shoulder is inherently unstable, and if you don't have a humeral head depressor for stability, that's where a lot of your pain's from. And the supraspinatus tendon, the top muscle of the rotator cuff, 4 tendons of the cuff, the supraspinatus tendon, the most common one injured, functions as a humeral head depressor. And to get this first 15 degrees of lift off, the only other real great humeral head depressor is the biceps. And when the biceps comes across the humeral head, attaches inside the joint. But if you lose the supraspinatus, the biceps, now this tendon is riding between the humeral head and the acromion. And so what happens is, cup of your shoulders here, the humerus starts riding up. So in a rotator cuff deficient patient, the humeral head doesn't even really articulate with the cup much anymore. It rides up out of the joint. So the rotator cuff being gone means that your shoulder joint isn't a real shoulder joint anymore. The shoulder joint is a ball and a little bitty cup and a great big ball. And when that muscle on top is gone, now you have the ball of the shoulder riding up against the acromion to where you can feel it grind. The humeral head articulation with the acromion is 3 times as large as the humeral head articulation with the cup in your shoulder. So if all of the pain is the humerus riding against the acromion, and none of the pain really is even affecting the glenoid because the humerus rides up out of the glenoid with motion, why in the world would you replace the humeral glenoid joint with a total shoulder or a reverse? Well, because that's all there was.
That was the only option presented.
That's it.
Yeah.
And it's either that or ignore it. So again, going back to the premise of almost everything we do, if it's that or ignore it. So either I'm going to cut the entire humeral head off and reverse how the shoulder was designed by God, right? So I'm going to take the cup and turn it into the ball, and the ball and turn it into a cup. I would not pretend to know more about how I would make a shoulder than the way we were designed and divinely created. So my goal would be to restore as normal as possible the anatomy of your painful body part, because that's what nature would want to do, and that should be our goal too. Not think that I can just make you better if I take all that stuff out and just replace it with something. Can you make it better? Sometimes. Is it easier to not burn any bridges and stand a chance of recreating normal anatomic function? Or let it wear out and stay functional by resurfacing what is now your new joint. Now your joint is humeral acromial joint. If I can resurface just a part of that, I can make a dramatic difference in how much pain people have.
It's almost like filling a cavity.
It is exactly like putting an innervated bone-to-bone interface with a non-innervated little protective cap on it that takes about 20, 25 minutes instead of cutting the entire humeral head out that's not even the source of the pain to address the problem that's not even really the problem. But still today, and this paper was published a decade ago, the most common procedure performed for a rotator cuff deficient shoulder, if it's the complete full thickness retracted area of the supraspinatus, is either surgical debridement, just stick a scope and clean everything up, which isn't bad, especially if you use cells, because you can get a significant decrease in the amount of pain people have. Or they just cut it out and replace the entire proximal humerus, replace the glenoid, let all the soft tissues fly, and you have dramatic instability with heavy lifting, pushing, and pulling, which you're restricted from. And the secondary failure of the biceps tendon is fairly dramatic. Secondary failure of the subscapularis, the front tendon in the shoulder that kind of helps provide stability to the biceps, is pretty dramatic. And the revision rate of a reverse shoulder can be 20% in the first 5 years. You can get prosthetic loosening. You certainly get a little bit of instability issues if you don't have the soft tissue capsule healthy around the shoulder. Or you get the most common problem treated in the shoulder, which is the exact opposite of instability. It freezes up and becomes so scarred and tight that you can't move it, and it hurts all the time. A rotator cuff only hurts when you do certain things. A frozen shoulder hurts even if you're not moving it, like riding in the car. You get people that can't lift a glass, and it hurts all the time. And oh, by the way, sometimes on the MRI, they're told there's nothing wrong. Okay. You should never have been told there's nothing wrong if you can't move your arm. You should have been told you don't have a cuff tear, right? But when someone comes in and says, well, they told me there was nothing wrong, I don't understand why it hurts so much. Like, can you raise your arm? Like, no. Like, so does it feel like something's wrong? I mean,
Yeah.
you know, I can't move my arm, it hurts all the time. It feels like something's wrong. Okay, especially in females, especially in post-menopausal females, even and the most common causes of frozen shoulder are that someone did something else to you near this region. So we're going to talk about the region of the shoulder. So if it's your left shoulder, it's not uncommon to have frozen shoulder after your pacemaker placement, after a mastectomy, after a breast biopsy, after a rough mammogram, where you hurt and they put you in a certain position for too long, and now you get this big capsular inflammatory load. You start having pain over the next 2 years. You can't hardly raise your arm. You can't roll over at night. You've seen 2 doctors. They did an MRI. The MRI looks pretty normal. Your family practice doctor ordered the MRI because he wants to know who to send you to, and he needs some information. And most family practice physicians probably just look at the report, to be fair. And if the report by the radiologist, because the radiologist doesn't know you can't move your arm, and he's not looking for inflammatory load, because a lot of MRIs now, especially in the cash pay world, may not do the sequence that shows the inflammatory load most, which is called a STIR sequence. And if you don't do a STIR, because instead of a 9-sequence MRI, you're going to do a 5-sequence MRI because it pays the same, and the 9-sequence study might be a little more expensive for them to shoot, and it takes a little bit more time, they'll do a 5-sequence study and tell you there's no cuff tear, no evidence of intra-articular pathology, no loose bodies, no labral tear. That doesn't mean you don't have frozen shoulder, because capsular adhesions or a decreased volume of the joint space and the secondary inflammatory load isn't commonly looked for unless you complain so long after a normal MRI that they do an arthrogram. And if you do an arthrogram and you put dye in the shoulder and there's no room for it, then they say, oh, there's evidence of adhesive capsulitis. There's evidence of frozen shoulder. And that is a really painful study. It takes a lot of people a long time to do.
It's another procedure.
It's another procedure. And so a lot of people never do that because they're already told by the family practice physician or the ordering physician, and I don't care if it's a family practice doctor, internal medicine doctor, your rheumatologist, sports medicine version of a family practice doctor, your physiatrist. Man, in some small towns, chiropractor, physical therapist. So that MRI, if they look at the report and they say, well, let's do more therapy, let's get you strong. But you can't because it hurts to move it. Your only symptom may just be pain. You can not even lose that much motion and still hurt all the time. Most of the time with a frozen shoulder, you get to where you can't raise your arm at all. It's easy diagnosis to make on physical exam, not on film. And instead of talking about either one of these papers, the rotator cuff paper, which we're going to bring up because I want people to know that, again, in our world, the evolution of stem cells came from me using them during surgery to improve your result. Now, what's happened over the last, because this paper was, the patients in the first paper on the rotator cuff paper were from 2002, 2003. The 10-year follow-up on those patients was published in 2014, so a decade ago. The 10-year follow-up is a decade old. That means for 20 years, we've known that the failure rate of rotator cuff surgery is about 30%. So now, worst case scenario, you've been told by the doctor, they do the MRI, you don't have a rotator cuff tear. Why do I hurt all the time? If someone examines you, gives you a diagnosis of adhesive capsulitis, if you look that up, what you're going to say is, well, at 2 years, it's pretty self-limiting, so you just go to therapy and you just hurt for a couple years. What? Like, that's your option? Now, do I think that anti-inflammatories in therapy are the place you should start? Yes. Because you don't even have to be right about the diagnosis, and that's probably not going to hurt someone. It's definitely not going to burn any bridges. So if there's a treatment that makes where you don't have any other options, and there's a treatment where you still have all your options open, do the one where you still have your options open first. So I think therapy and anti-inflammatories and stretches and cold, hot, laser, whatever that gets you better, peptides like BPC 157, there's some great options, right? So if I just make it where your body can handle the inflammatory load, and again, the big risk factors for adhesive capsulitis, the biggest one is surgery. Because if you operate on a shoulder and you've caused this big capsular inflammatory reaction, because it's going to scar in if you're not stretching it out really fast. And unfortunately, still about a third of the rotator cuff patients that have surgery are in a sling for 6-8 weeks. If you're not moving that joint very quickly after surgery, your chances of not ever being able to move it again on your own without a second procedure is really high. So taking that sling off that next day and that night, doing Codman exercises where you bend forward, hang your arm, you make these, the circles one way, let it relax. There's a whole set of exercises we give everyone because I don't keep you in a sling 6 weeks. In our practice, even after a big rotator cuff tear, certainly after rotator cuff arthropathy, where I'm just putting this little cap in, we get people out of the sling within the first 2 weeks. We get you moving. You can take your sling off the next day and eat. You can do the hanging arm exercises. Really, the only reason I even want you wearing a sling is to keep you from grabbing your shoulder, trying to shake your hand because it's going to hurt. Not because it can ruin anything we did, but because it's going to hurt. Matter of fact, what's published with rotator cuff surgery is a third of them on MRI at 6 months aren't healed. And it's never going to get better than that. The 6-month data, like if it was going to happen, it happened. A third of them didn't heal. By altering what you did at the time of surgery, same surgeon, same hospital, all they did different, half of the patients, they took their bone marrow, concentrated it down into bone marrow aspirate concentrate using their patient's autologous stem cells, and injected into that area of the proximal humerus and the rotator cuff. And actually, in the first study, just the rotator cuff. By doing that injection at 6 months, 100% of those patients were intact. In the control group, same surgeon, same hospital, randomized. I didn't just pick the easy ones to put bone marrow in, the bad ones to not, which happens, but didn't. The patients that didn't have it, only 67% were healed at 6 months. 100% of the patients were healed at 6 months that had it. Now, because that data is really overwhelmingly impressive, I thought it would be kind of a drop the mic moment. Didn't change the narrative at all. The 10-year follow-up was published in 2014 in the International Journal of Orthopedics. Dr. Hornigau's study out of Paris. Dr. Hornigau, at 10-year out, the 10-year follow-up is, if you didn't have autologous biologic cells put in your cuff at the time of your reconstruction, 44% of those patients were intact on MRI. If you had autologous cells put in your shoulder at the time of the reconstruction, 87% were healed at 10 years still, right? So 100% at 6 months, 87% at 10 years. No cells, 67% at 6 months, 44% at 10 years. To me, now, so that's, this is new data. No, that study was published in 2014. So we're not talking about something that you shouldn't be able to hold the person taking care of you responsible for. In every shoulder we've done for way more than a decade, the first step I do is while you're asleep, I prep out your iliac crest. I make one little poke hole. We harvest 60 cc's of marrow. We put it in the cell concentrator. It spins out the stem cell volume and gives you the PRP version, platelet-rich plasma, with cells, because remember, only about 3% of bone marrow is a stem cell. The rest of it's whole blood. But you're going to take that mass and you're going to inject it, injection into the proximal humerus, because guess what? You know what's interesting that we didn't know when that study was published? What we didn't know is maybe the reason that rotator cuffs fail so often isn't just aging and delamination of the tissue. It's because the stem cell volume at the tendon attachment site of the proximal humerus is really good until guess when? Around your 50s. And then when you aspirate marrow from the proximal humerus, which we've done, because that's one of the reasons I designed that catheter, you could take marrow from the site, you're going to repair it. But guess what happens when you do that? Not a lot of cells in it. So, because a lot of the nourishment to that rotator cuff attachment comes from that area of the proximal humerus, is it the cuff delaminates and tears from the chronic stimulation, the pulley being too tight, and the rope gets old and dried out? Or is some of it, the answer is yes, if you're following along, is some of it because it used to have really good stem cell concentrate to help keep the tissue healthy, marrow aspirate. And as you get older, those cells, there's not a lot of them left in the proximal humerus. It's iliac crest, lumbar spine, proximal femur. If you're taking cells out of an ankle or a calcaneus or a proximal humerus, not a lot of stem cell volume there anymore. That's why our draw isn't just in the proximal humerus when you do a rotator cuff. It has to be from the iliac crest. That's one of the reasons not a lot of people do it, because it takes about 15 extra minutes and you don't get paid to do it. But if you're doing the rotator cuff and someone's getting paid to do your rotator cuff, wouldn't you want to have the best possible result? I would want at 10 years to be the 87% instead of the 40%. If I knew, matter of fact, I think that this is a discussion you need to ask your surgeon. If I knew, if I looked you in the eyes and you said, look, a third of these never heal, my first question would be, you sure I need that done?
Or you're going to try
well,
and put
if it's
it
your
off.
only option,
Yeah.
if every problem is a nail and I only have a hammer, great. What if you have a screw and I have a hammer? I'm still going to drive that screw into place, right? Like maybe you need to ask the guy if he has a screwdriver handy, right? Like if you're going to get in there, when you get in there and you find this, what can you do to tilt the scale in my favor to help me get this problem healed? And that would be bone marrow aspirate concentrate. And you want to do it correctly. You want to inject the tendon attachments. You want to inject that proximal humerus. Now, do I still aspirate that area of the proximal humerus? Yes. Because then if I aspirate and inject, I get rid of the lake of inflammatory component. I increase the perfusion. I get that body part moving again. And I'm going to inject something healthier in that. You fill up the lake. The solution to pollution is dilution. Every other version of science will tell you that. And so do that. Like tilt the scale in the patient's favor. What about, is there any other biologics you can use that's legal and has been shown to make a huge difference in wound healing? Hey, there's this patch, hundreds of different ones from postnatal tissue, ethically sourced after a C-section. Everyone say along with me, healthy mommy, healthy baby, healthy membrane, all genetically tested, right? So we're going to say that a lot because that's important, that it's after a C-section, we were throwing it away, and it's genetically tested to be safe, and it's been used in wound care since 1910. So it's not been important for more than 100 years, but now it's way better than it was 100 years ago because we don't have to just kill everything in it and bake it and radiate it. You can take this little patch of amnion and you sew it over top of your repair. And how we use that little patch of amnion is by sewing it over top of that repair and then taking those cells and kind of inject through that. We kind of create a little bit of a barrier and an adherent, and it helps kind of keep the cells where I want. And guess what happens? Do a third of those patients fail at 6 months? No. Is the post-op complication rate of adhesive capsulitis approaching that 5, 10, 15% mark? No. Why? Because I'm going to trust my repair. I'm going to get you moving soon. Look, if with the way you can repair a cuff, it's bone anchors made from artificial bone substitute, a big suture bridge where you can kind of create a lattice across the top of the cuff. Can I get you moving even if it was never going to heal? Would that suture augmentation, the suture bridge, the anchor system that we use, could I get you moving and just let that be the only thing stabilizing it? Yes. Is it going to fail eventually? Yes. But it'll get you through the first 3 to 6 months. And guess what happens over the first 3 to 6 months? The cuff heals. So then the cuff takes over the work. I don't have to trust my repair for 2 years if your cuff's going to heal. I have to trust my repair for 3 to 6 months because then your cuff will be healed. The repair won't even matter. You have a healthy cuff, right? So rotator cuff repair. If I get you moving faster, you don't have frozen shoulder. What about you didn't have a rotator cuff repair? And that paper is International Journal of Orthopedics 2014. Everyone that comes in my clinic with a rotator cuff injury probably has a copy of that. Because I know that when they go back to their family practice doctor or a lot of them, wherever their local physician was, because a lot of our patients come in from St. Elsewhere, which, man, I hope that some people get that reference. Everyone my age will get it, but I don't know that everyone in this room is going to get that. But when they come in from St. Elsewhere, they're going to go back and say, hey, this guy says if I don't do it with stem cells, it's not going to work. I didn't say that. I read the paper that showed that. I'm just a purveyor of scientific literature that has tried to take everything that's already been published and not reinvent the wheel, but find a better solution for you based on science, physiology, and what's been published. If there's not anything to sew together, that was kind of the unanswered problem. That was the reason for the hemicap.
Yeah.
And, man, this has been a long discussion to get to this, but
well, there's a lot of involvement, right? There's a lot of steps, a lot of things.
The shoulder is a complicated area of the body.
Yeah.
Because, a lot of people, and I won't spend a lot of time with it, but a lot of people that come into the clinic that have already had a total shoulder and still hurt all the time. It's not even their shoulder is really what was hurting. They have a disc. If you have triceps pain, muscle in the back of your arm, the triceps, if it's hurt mid-triceps, mid-humeral bore, you can't even move, it's killing you at night, you find yourself talking to people and doing this. Like I would literally be looking people in the eye and doing this to my arm. Guess what the problem is? Is it your shoulder? No. Did I have a bad shoulder? Yes. Did I think it was my shoulder, even as the orthopedic surgeon that should have known better? Yes. Right up until my grip strength started going away, and the pain got so bad, even at rest, that even the orthopedic surgeon, you have to thump in the head sometimes to get his attention, thought, you know what? This is coming from my neck. Because a 6-7 disc or foraminal encroachment and radiculopathy causes what? Triceps pain. Oh, this isn't even my shoulder. Do I have a bad shoulder? Yes. Does it hurt when I moved it? Yes. Is that what's causing my mid-humeral border triceps pain that was keeping me awake and making it where I couldn't stand it? Yes. Do a cervical epidural while the numbing medicine's in. Did all my triceps and shoulder pain go away that was caused by my neck? Yeah. So guess what? 2 neck surgeries later, still had a lot of pain until we did something with cells as an epidural. But so a lot of things that cause shoulder pain aren't even the shoulder, right? Cubital tunnel, the nerve at your elbow. If these 2 fingers are going numb, it's waking you up at night, you're losing grip strength, it's either a disc in your neck or a nerve at your elbow. Can it cause shoulder pain? Yes. Why? Because it's like a garden hose. If there's a kink in the hose, you don't know where it's at. Pressure builds up at the faucet, nothing comes out of the hose. The doctor should listen to you, ask you the right questions, do the right study, sometimes a nerve study, sometimes MRI, sometimes both, and figure out what's really causing all your shoulder pain and how do I get rid of, if there's 5 things that are targets for why you're hurting, let's come up with a flowchart approach, get rid of the easy things first. A lot of times it's just carpal tunnel. Maybe it's not the triceps hurting. Maybe it's the anterior deltoid. Maybe it's the deltoid attachment. 4-5, 5-6. Oh my gosh. So sometimes my hand does bother. You know, at night it wakes me up. If you have carpal tunnel, adhesive capsulitis, maybe a little disc in your neck, could all those be causing you pain in the same area? Yeah. What's the easiest thing to fix out of all those? Carpal tunnel is a 1/2 inch incision and it takes about 5 minutes. If you have a nerve study that shows you have carpal tunnel and you're waking up at night shaking your hand, you can't hold your phone, your arm in certain positions, and you have this vague shoulder pain and neck pain and pain between your shoulder blades, is that from your rotator cuff tear? No. The fact that you can't move your arm, is that from your rotator cuff tear? Kinda. Is your rotator cuff tear what's causing the pain? No. Adhesive capsulitis or frozen shoulders what's causing the pain. Is there a really easy way that we've developed in the clinic over the last 10 years to treat that doesn't follow the Western medicine narrative? Yes. And the reason we're going to talk about this is because it's one of my favorite examples of how a body wants to take your pain away. It wants to scar it in so much that you don't move it because it makes it more stable, and it will not let go because it's more interested in stability than it is the shoulder coming out, right? But as things scar in, because remember, inflammation, which is the key to all diseases, but inflammation is also the start of healing. So you get these inflammatory cytokines, it's going to start to get inflamed, and then it'll turn to remodeling and secondary healing, except when it doesn't, when you get stuck in an inflammatory load because you're not 19 anymore. And if you get that stuck in the inflammatory load, now it's like that old balloon in the back of your car that gets all heated up and it's all stick together, and that's the shoulder capsule. Would you just tear it apart? No. You blow in it, kind of massage it, blow in it, break those adhesions loose. So if I fill it with air, I can break it loose. Can you fill the shoulder with air? No. Can you fill the shoulder with steroids and local? Yeah. Is that going to get the balloon broke loose? For a little bit, and then it's going to be worse because steroids kill tissue and local kills tissue. Not as bad, but none of them are anabolic. None of them build it up. So if you break it loose a little bit and move it around a lot, maybe. is there something better that you could put in there that would break it loose, lower the inflammatory load, set you up for success, and move you forward? Yes. Any of the biologics that you inject intracapsular under fluoro, prove the needle's in the joint, do the arthrogram, fill that capsule up with the patient asleep in kind of twilight, move their arm around, break all those adhesions. It's called Spencer's maneuvers. They have this, set of, you move that arm around, guess what? The patient wakes up and does this, right? And I think of all these in terms of patient stories. I know you'll remember. Because it was one of those kind of moments where you kind of say something as an example and then it has a more important meaning for the patient, right? Because the patient has a stroke and they've just kind of given up on her right side. But then she hurt her left arm and it froze up. And because she didn't have a big cuff tear, everyone just told her there's nothing to do. She'd been in therapy for years and wasn't getting any result, hurting all the time, now can't roll over, and her stroke side's frozen because it didn't have to, but because if you can't move it very well, it's going to freeze up because that's what happens when you're an inflammatory mess. So they come in for her right shoulder, look at the MRI, examine her, and patient's like, look, she has to have at least one arm. She can't even pull her pants up, and we need help. Like, what do we do? So, well, I won't promise you anything, but here's what I think we could do. We did it. Post-op, she's raising her arm, all her pain's gone. Like 2 weeks out, her result has been phenomenal. So they come back in. I'm thinking, wow, what? There is something wrong. They're like, okay, so this is done so well on the right shoulder. Is there something we could do to the left? Because her stroke side, she has no motion, and we know she doesn't have a lot of strength, but she's getting function back. She's worked really hard. Stroke was a few years ago. Is some of this bizarre inflammatory stuff coming because it's all froze up and she can't move it? The answer is probably. Is it worth doing to that side? First time I'd ever done it. I don't know. Like, can it hurt her? Well, no. Is there say it all with me, is there a downside to injecting that and moving it around? Other than the economics, no, because insurance ain't going to pay for it. But hey, I have a private OR. Anesthesia is way less expensive over here than it is next door because the insurance contract doesn't allow the provider to contract you for that if you're doing a covered procedure. But is there a way to see if this could make a difference? Well, did it help the other arm? Yes. I'm dramatically better, and they told me there was nothing to do. Okay. So we did it. And in recovery room, as the patient was waking up, because I'm just as anxious as everyone else is, because on the objective data that I get, so when a patient's asleep and you put dye on the shoulder and you can watch the dye kind of break loose, objectively, I get that needle in there, there's no room. You go to put dye in it, and all of a sudden you can watch it break loose. We use a big caliber needle and little bitty syringes so I can generate some pressure. You can look at C-arm as you're putting dye in and you're watching the space get better. Then I put a bunch of the biologics, break all that loose, because now I know it's not about 1 cc where the pain is. Sometimes it's about washing out the inflammatory load and getting some mechanical stimuli to do that. So bigger needle, because patient's asleep, and a bigger volume, and not 10 cc syringe that you can't generate enough pressure. 3 cc syringes, where I can just put a couple 3 cc syringes and generate a lot of pressure across that needle. You're looking at the serum, you watch it break loose, you go to move her arm, and what I couldn't hardly move when we first put her to sleep, because part of my exam is always when we first put people to sleep, because it doesn't hurt, and I get a lot of significant physical exam findings from that. Physical exam's dramatically different after you inject it. Move the shoulder around. Everyone's in anticipation as we get to the recovery room. As she starts waking up, I said, hey, I know that there's about, and this is where the statement came in that was way more emotional, meaningful than I knew it was going to be. I said, I know it's not dramatically important unless you're going to be calling touchdowns, but can we get both your arms up? And she does this. gets her arms all the way up. And I'm like, that's awesome. And that's the stroke side moving. And because it wasn't necessarily the stroke, that it's just a stroke why she had weakness, but it was the capsular adhesions that kept her from being able to move her arm, and they just blamed it on the stroke. Now, when she raises her arms, and I said, I know you never really need to do that to call a touchdown, the patient almost starts crying. And I was like, I'm sorry, does it hurt when you did that? That's my biggest worry, right? Mm-hmm. And she's like, no. She goes, my husband that passed away, like in the last 2 years, right? I mean, that's why she was so desperate to get this done. Well, the sound producer's gonna hate that, right?
Hey,
I'm gonna get dirty looks. I'm not looking over there. She said her husband coached football, and she goes, one of the biggest joys was, so if you're watching a football game and you're vested, your husband's coach, when someone scores, what do? I know what me and my daughters do. Yeah. We throw our hands in the air. We call a touchdown from the sidelines way before the referee calls it on the field, right? And she hadn't been able to do that in years. Like, that's why the story sticks there, right? Like, there's some emotional cue that made it stick there for me. But it was life-changing. Yeah. And we did almost nothing, right? Put a patient to sleep for 10 minutes, injected biologics, moved it around while she was asleep after an arthrogram.
But how cool is that moment, right? I remember I walked by and I saw her in recovery, and you're like, hey, Mike, come look at this. And you said, do it again. She throws both arms up. I grabbed my phone. We snapped a photo.
I got a great picture of her in recovery room bed, right? And I'm standing next to her like.
It's one of those moments that just reminds you why you're doing this, right?
Because again, because we're not afraid to integrate a lot of technology and address a problem in a way that may not be common. But it certainly makes sense. What does they say? Common sense is not common. All it has to do is make sense and have good science, physiologic understanding of the science, and an ability to apply some of it. That's all we're doing. In 2012, 2014, 10 years out, the paper on the hemicap, the hemiarthroplasty for a rotator cuff deficient shoulder in an attempt to avoid arthroplasty, that because you don't have a cuff, may have some significant inherent stability and has a much higher failure rate and is a significantly more invasive procedure. The hemicap paper, it's hard to argue with the results. Like, hopefully you're going to see a video because the first year we did this, people would come in, no rotator cuff. They've been told by 5 doctors they'll never be able to raise their arm, and everyone on video is raising their arm. Yeah. And at like 6 weeks with no cuff, and they've been out of a sling the whole time. Like, if I'm replacing that little area and not reconstructing a cuff, I keep you in a sling for a few days just for pain, but I let you take it out, hang it down. I want you to swing it when you walk. I want you to get as rapid a return to motion as you can, because your shoulder was adhesed and frozen when I did this, and I don't want to let it come back.
It becomes infectious just with the results, right? And so you're the first physician I ever worked with that invited me into the clinic during a post-op visit, right? As a rep, you're there, you're the tool guy, you bring your stuff.
You need to be vested in your result.
Yeah, so you called me and you said, hey, make the trip up. This will be worth it. And I go into the patient room, and there's this sweetest old lady. I mean, I don't mean to be disparaging.
Yeah, but she's like 85.
She's a delight, right? She's just got that attitude.
One of those patients that had been told she was too old for a shoulder replacement.
Yes.
The only reason she even came to us.
Yeah, and you looked at me and you said, she's never going to throw a fastball, but I want you to see this. And you said, come into the room. I walk in. You said, raise your arm. And she just makes this little ha-ha as she lifts her arm up. And it was graceful, right? Yeah, it was with as much grace as you could ask. And after that, I don't know if you remember, you would send me videos every month of more and more patients. So it kind of stirred something in me. And I remember I came to you and I said, we've got to teach more people how to do this.
There you go.
And so the culmination of it kind of, I went way outside.
You were the driver, though. That was because corporately, they weren't sure you're going to be able to teach an old dog new tricks.
They didn't want to support it, right? It didn't fit the narrative. It was hard to explain all of this.
Takes a little bit more time. It's an hour-long podcast to describe it with the guy that developed it.
Right.
Like you can't, if you can't explain it in 10, 15 minutes to a patient, and you're going to have to try to reinvent the narrative of avoiding a complete shoulder replacement. And they already have a shoulder replacement on the market. Why are they going to cannibalize their own market when it costs a lot more to do a shoulder replacement, and that prosthesis makes them a lot more money than this little cap?
Oh man, and listen, the company, I love their
Great
inventions.
company.
Yeah, I love their inventions. I had no support, so I hired a film crew. We taught them sterile technique. We got them credentialed. We got them into the OR. We documented and filmed you narrating one of these shoulder cap procedures.
Because we had to teach the approach. Because if you do it with a standard approach, you're de-innervating the anterior third of the deltoid. And if you don't have a cuff, you know what you have to have? Deltoid.
Yeah.
And so if you do a standard approach and you de-innervate part of the deltoid, you're not going to get a great result with this procedure. So I had to design a way to do it to be able to get the results we have. And we did.
Yeah.
But we didn't, but teaching it was kind of difficult. That video turned into a lecture at an Italian shoulder and elbow conference that was really well attended. It's a really big one.
It was two people really passionate about a project. It was you and myself in your living room.
Yeah.
And I remember I got to your
At
house
like
at
6 a.m.
Yeah, 6
right?
a.m.
So
man.
Mike shows up with Starbucks.
Oh,
we're in my living room on a WebEx call.
Yeah, this is before Zoom, before all the Teams and all the meeting programs.
It was before virtual learning.
Yeah. And I set up a tripod and a couple cameras, and man, I had no idea what I was doing.
But we did have the coolest lecture experience ever, because we gave an hour lecture on rotator cuff deficient shoulder and humeral acromial arthroplasty, and we're able to show the video and split screen on one side as I was giving the lecture and narrating on the other.
Yeah, it was amazing. I got to watch footage of all the physicians. There were over 350 physicians in that room, and for me, it was goosebumps. It was chills. It was like, holy cow! I get to just watch, right? And it was just amazing, because while you're talking, you're watching the surgical video, you're narrating it live for all these physicians, you're answering questions and giving pearls and tips, and they're all just leaned forward in their chairs and paying attention, because I'm watching the camera on my laptop of them.
Yeah,
and it was beautiful, because it was a different way to view repair of a shoulder that had no cuff left. Right? And it was great.
Completely unexplained.
Yeah.
And still misunderstood. And still the largest thing we have is thrown at a problem that could have had this much of an intervention. I don't even cut any humeral head out. We don't cut any glenoid out. We put this little cap on top to protect that surface and make it way less friction. It all scars in anyway. So the scar tissue of it is kind of de-innervated. But if it's scarred in and bone rubbing on bone instead of a little shiny metal cap rubbing on bone that doesn't hurt, people can't raise their arm. But we're taught they can't raise their arm. It's not that you can't raise your arm. It's that pain, when you go to raise your arm up, the humerus is being driven into the acromion. And so as you go to raise your arm, you have this pain of bone to bone, because that's how you're going to get your arm up. And your body says no. So you go to raise your arm, and it feels like it kind of gives way. It has not. If I make it not hurt, you can do it. And you know how I know that is because before I ever did any of these, I would take a patient to the room. I would fill their shoulder up with just Marcaine, and after a few minutes of doing some hanging arm exercises, I would see if they could raise their arm. And guess what? Without a rotator cuff, if they weren't frozen, it was amazing how many people, if you just get rid of the pain response for a couple minutes, could raise their arm. So do you need a rotator cuff to raise your arm? Nope. People are like, oh, yes, you do. No, you really don't.
Yeah.
You just need to not have adhesive capsulitis, and you need to be able to have something that mitigates the pain response so you can get your deltoid function back. So anyway, so hopefully what people get out of the episode is that a lot of things can cause shoulder pain. So make sure your diagnosis is right before you let someone cut a big chunk of bone out of you. And this episode only came about because there's 3 patients in the last week. One has had a shoulder replacement, a big reverse. They cut out everything, big stocked bone, and he is worse. He's dramatically swollen, and he can't move his arm. It hurts all the time. Okay, is that what he had hoped for when he decided to have that giant surgery at St. Elsewhere? No, right? So is now, and we kind of stuck with trying to figure out some less invasive options for him? Yes. Have we been able to navigate the waters a little bit to make a difference? Yeah. Then we see a patient this week. He's had one view shoulder and no physical exam. By the patient's report, the doctor didn't even move his arm. He looked at one x-ray of his shoulder, no MRI, and said, you need a total joint replacement. I don't even know if it's going to be a reverse or a traditional until I get in there. Now, should you know if it's going to be a reverse or a traditional before you get in there? Yes, because if there's no glenoid bone stock, which you should know based on an MRI or CT, and if there's no supraspinatus tendon or subscapularis, you should know before you get in there based on MRI. Oh, and by the way, is your shoulder frozen? Because the guy's not bone on bone. He doesn't have humeral head collapse at all. He has no humeral head deformity. Could you have known that by just moving the guy's arm? Yeah. Would I want someone to move my arm around, maybe give me some pain relief, let me get some motion back, and see if I need a humeral head replacement, a total shoulder? Probably. Did they do that for him? No. Is it really easy to make a dramatic difference from someone that was already scheduled for a total shoulder and doesn't need it to get restoration of function and relief of his pain? Because that's what happened. And the frozen shoulder patient that has been told there's nothing wrong, but they can't move their arm. But they've been to 3 doctors and no one moved their arm. You know what we had to do to get all their motion, to get their shoulder replacement to not be a thing? Put them asleep, inject the shoulder, and move their arm. Took 10 minutes. Like, why even avoid that? Like, we didn't even do bone marrow. We did PRP because all I need is volume of biologic to not get it inflamed to get your motion back. Anyway, so those 3 patients are the reason for the episode this week. Hopefully those patients know who you are, because I'm genuinely humbled by the opportunity to take care of you and inspired by your confidence to buck against, to know intuitively that it sure seems like this is a big step. Yeah. Like the patient, there's a sense of incongruity that made him come see us. If they had complete trust in everything that had ever been done for him on the surgical side, because the guy that has been told he needs a shoulder that doesn't even really have that significant of arthritis on the one view they did and no MRI, they did his other shoulder years ago, and he hasn't done that great. Because if he did great with his other shoulder years ago, and they already have him on the schedule to do this one, would he have already had it done? Yeah. Why hasn't he had it done? Because he already had it done to the other side and he didn't do very well. That's a pretty smart guy. Yeah. Because he's not going to just let him do the same thing that didn't work already. But you have to be brave. Because he's already been told by some expert that there's really nothing to do with this. Yeah. Right? So the patient is being your own advocate and taking responsibility for your health care is what does that. Not a lot of people are capable of that. There's not a lot of people question authority anymore. That's how we got where we are right now, right? Don't get the old guy on the rail against the machine about being afraid to question authority or being afraid to question the narrative. The narrative is rarely right. If everyone agrees, it's probably wrong. The dissenting opinion can be the most important one. So be the dissenting opinion when you're your own advocate, especially if you're your only advocate. Question and find out all the other answers. This search is, I'm going to try to make it easy for people because I'm going to give you expert information that's already been published to help you rail against the authority and make decisions on your own behalf.
Yeah. Lastly, this brings us back to one of the first points you made, which is have someone in the room with you, right? So that you can look at them and go, hey, doc wants to completely change the anatomy of my arm because my shoulder hurts.
Because I can't move it.
Right. So, but that's it, right? Being an advocate also includes having somebody to bounce that idea off of, right? Did that sound right to you? Kind of conversation.
Did that sound like a little bit too much?
Yeah, like trying to replace your front door by removing all the drywall and brick around it. You know, that kind of thing. Yeah.
Hey, lastly, before we end, because I want to make sure we do this, because it had, you know, I love epiphany moments, right? And there's a book that I read while my daughter was graduating high school, and now she's a college graduate, so been a bit. And I love this book, so I brought it in because Atomic Habits, I think, James Clear, great book. And there's a great story in it about I'm going to get the guy's name right because I think that going I just look at the data real quick. Yeah, so I need to be more legible in my handwriting and not just take a last minute note. Stephen Luby, he's apparently an amazing person because he bought a one-way plane ticket to Pakistan from Omaha, Nebraska. And Pakistan at this time, Karachi, in '98, right? Maybe not the safest place in the world. Actually, Karachi was listed as one of the most populous cities in the world, 6 million people. And oh, by the way, one of the least livable cities in the world. And diarrhea is endemic. 50% of the population has diarrhea. 50% have pneumonia. 50% have dramatic impetigo. Like it's endemic. But again, sometimes it's about debulking a situation to let the body do what it could do. Most of what we talk about with cellular medicine and peptides and high-dose vitamin C and nutritional therapy and muscle stimulation with electromagnetic forces to get contraction. Oh, hey, how about the secretion of myokines by getting the muscles activated and getting inflammatory change out of the way to generate those healthy molecules you need? The endemic diarrhea, the impetigo, the pneumonia, was that an unsolvable problem in Karachi in '98? Stephen Luby lowered, in less than 6 months, lowered diarrhea by 50%, lowered pneumonia by 50%, lowered impetigo and skin infections in children by over 30%. Oh my God, they introduced antibiotics and put people on medicines. No, he brought Safeguard soap to Karachi because everyone kind of knows hand washing is important, but it was not a pleasant experience. And a lot of people then would just wash one hand and they had sewage issues. So the body is overwhelmed by bacteria and things it can't defend against. Just using soap, does Safeguard soap, does it just kill everything? No. You know what it did? It presented the bacterial loads in a low enough format where your body could take over and get you well and prevent you from getting sick. Is that kind of what cells do? That's what's published, not my opinion, but certainly, is that what peptides can do? Yeah, it gives your body a naturally occurring peptide to help overcome some problems. Does it cure stuff? No. Did Safeguard soap cure diarrhea? No. Did Safeguard soap cure impetigo and pneumonia? No. Did it give your body a fighting shot at lower bacterial loads and lower chronic inflammatory change from the cytokines of sewage? Yes. Do we need to think of a lot of things in our body as just soap? Like, you know, when problems are overwhelming to the body, can I get your body where it could fight back? Like, give people a fighting chance. Guess what soap did? It gave them a fighting chance. Now, the whole book is about developing a habit to wash your hands, and it was an incredibly difficult habit to get started, but when he made the hand washing experience more pleasant, and they gave people their first bars of Safeguard soap, which is what they did, 6 years later when they came back, guess what 95% of the population that was in their study were still doing? Washing their own hands with Safeguard soap because they saw the result. Were they still giving them free soap and was the study still going? No. Did they come back and recheck on people? And again, because they developed the habit and that's what Atomic Habits is all about, is easy ways to hack developing a better habit. Great book. But my point wasn't even the point James Clear's making in the book. My point was, all they really did is debulk the bacterial load that's fighting against you getting sick. And your body could keep you from getting sick if it was given a little bit more of a chance instead of too big of a fight to win. Diarrhea was only 50%. So 50% of the people, even in that unsanitary condition, were still able to fight back. 60% of Karachi in 1998 was living in squalor, no indoor sewer, off the power grid, in one of the most populous cities in the world. It was the least livable city. Soap, right? Again, because those people's body, your immune system, give it a fighting chance. Anyway, I thought it was an important point because it's so much the way we think about all of the problems your body has to overcome. With cancer, right? Everyone has cancer of every minute of every day. Does it kill everyone? No. Why? Because a lot of people's bodies, especially cancer cells, they're not the healthiest cell in the body. No one gets irradiated and becomes Superman. The cell doesn't become a super cell. Now, if you look up super cancers right now, you get on a bad list. But because there are some things that can limit your body's ability to fight back that have been done to the world, and Hannah's going to have to cut that out. Like, you're going to see probably if you're watching the video on Twitter right now, you're going to hear what I'm saying. If you're watching it on YouTube, you're going to see a little disclaimer that points you to my Twitter channel, because YouTube's not going to let this episode stay up with this in it. But certain things that hurt your immune system keep you from fighting back and can make cancers grow unfettered, the same way bacteria grow unfettered without soap, right? So is there a way to give your body a fighting chance? Yeah. Do most people even need that? No, because the body is able to fight back on all those cancers. That's the reason no matter what cancer you had at the minute, your body does a pretty good job of taking care of a lot of that. When it's healthy, when you're hitting on all modes, when you're not stressed, when cortisol's not high, when you're not loaded with environmental toxins, and other people, other things in your body put you at risk of that cancer winning. Just like not washing your hands put your body at decreased ability to win the battle against diarrhea, pneumonia, and pemphigo. Right? Think of that when you're having a health issue. What can I do to increase my overall wellness, where my body may be able to fight back, defend itself, and win this fight? It doesn't always have to be a shoulder replacement, a hip replacement, a 3-level fusion in your back, or giving up, being in a walker. We have a patient, we have a patient last week. Guy's in a scooter. His son texted me this morning. Dad won't stay in a scooter. He wants to walk everywhere. He had been told, because maybe he needs total knees, and it's not a great option in his health state at this point. Like, you just need to be in a scooter. Was that true? No. Give the body less of a hill to climb, and it is amazing what the human body will be able to accomplish with the right resources and management of the surrounding issues that are causing the dysfunction. It's not all one problem. Sometimes it's about debulking the problem into an easier problem. Take 10 problems, turn it into just kind of one, and see what the body can do with it. Anyway, I know this is a long episode, and because I knew it was going to be a complicated topic, because we're discussing shoulder pain as an entity, and everyone's going to have shoulder pain pretty much at some point in their life. If you've been active at all, because everything that you've ever done leaves a little bit of a mark. And so if you've been doing a lot, and it's going to hurt. So thank you for your attention. Mike, do you got anything to say
Dr.
before
McKenna's
I do my little mea culpa?
I really appreciate today. This has been a fun kind of walk down memory lane, and kind of re-inspired me to go back and look at old videos. So it's been a lot of fun. I really appreciate the opportunity you gave me and letting me come back after screwing up on the study I brought into your OR, and kind of the friendship that evolved. So I appreciate that.
That was 15 years ago, right?
A little more than that.
Yeah.
I got older, you didn't, but
Oh no! I'll tell you right now, the hardest thing for me ever is going back and watching that video, because the Dr. Wade McKenna in that video looks like he's breathing hard to get in that chair, and it is pathetic how much I didn't fight back against what was happening to me to debulk the problems and try to stay a little healthier. And with that, I want to say, first of all, thank you, Mike, because a lot of that, because he was able to take the good-natured ribbing and become a friend. And mainly because I like being inspired by the people around me, and sometimes I have to be reminded to enjoy some of the successes and not just continue to focus on problems all the time. So thank you very much. We're humbled by the ability to take care of you. If you made it to this point in this episode, thank you. And it probably means your shoulder hurts, and that's why you paid attention. And if that's the case, please know that we would do our best to take care of that for you. Like this episode, if you got something out of it, please subscribe to the channel and leave a comment if there's something, especially if you're one of the patients that's been affected by some of what we've said. It means a lot when we get positive feedback. I will tell you that the meeting today started with the producers reading email from a patient that is really pleased, and it is humbling to get that kind of feedback back, and it's what keeps us going. Railing against the machine gets exhausting sometimes. Preaching to the choir is great, but trying to fight back against a big narrative, sometimes it can be a little overwhelming, and without your love and support, everyone gets to a point sometimes where they question why they're working so hard to do that. So thank you very much. It's the patients that inspire this, and thank you.